Good morning. Thank you for the invitation. I'm sorry to say, Dr. Kansasamy talked about what he talked about. I'm a clinician. I'm not a researcher. It's also always nice to cite scientific presentations, but as Karl Popper rightly says, scientific knowledge is the best and most important kind, though I am far regarding it as the only one. And if we want to cite scientific articles, I like what Dr. Jeff Occlusion usually says, and he says, if you're in favor of occlusion, you cite these articles. And if you're in favor of against occlusion, you cite these articles. So see, I could stand up here and show you articles defending of what we do, because there are a lot of articles, maybe not in the orthodontic literature, but yes, in the prosthodontic literature. But I'm not here to cite articles. See, I'm a clinician like most of you. I'm here to help you treat your patients. That's what it's all about. It's not about what an articular does or does not, or if it's proven or it's not proven. It just makes us better diagnosticians. It's more tools in your toolbox. Why would you not want more tools in your toolbox if you're going to make a better diagnosis? So why all the fuss? Why all the fuss? See, this is not going. See, I want to present to you 3 patients. Each patient was treated differently. But look below. All of these patients had been treated previously by TMD specialists. See, it would be nice to believe what Dr. Kansasamy said, that patients adapt. If patients adapted, my office wouldn't be filled with TMD patients. Unfortunately, not everyone adapts. That's not the truth. We have a lot of patients who suffer from TMD. Why don't they adapt? Not everyone adapts. And see, all of these patients were treated according to the Charles Green biopsychosocial model. And they've told us that it's no longer a dental-based model. You know, that's like telling me that a transmission doesn't move the 4 wheels of a car. How can you say that teeth do not play a role? It's impossible. Let's be a little bit more anatomic reasoning. See, it's not about centric relation. Why does he continually see centric relation, centric relation, centric relation? Today it was here, yesterday it was there. Who cares where it is? It's not about centric relation. I think centric relation should be erased from the map. See, it's about orthopedic stability and orthopedic instability. See, it's a joint like every other joint in the body. And what we want are orthopedic stable joints. And in order to have orthopedic stable joints, there must be harmony between the teeth and the joints. If there is not harmony, it will not happen. And like Jeff Occlusion says, when orthopedic instability exists, there are opportunities for overloading, injuries such as tooth wear, periodontal changes, and TMJ alterations. See, it's all about orthopedic instability. Let's look at our first patient. This is a true story. She wrote this with her own hands. She was treated according to the biosocial model, eliminating the teeth from all of her problems. Can you believe this? Splints, physiotherapy, trigger point injections, ozone injection, prescription drugs, auto-emo, ozone and blood mixed and injected back into the body. Special diets, plasma-rich in platelets, celestone, beta-metasone. 6 years of treatment according to the biosocial model, and she was still in pain when she came to our office. Something is not working. What the literature says might not hold all of the answers. This is her occlusion. You can see she has dental abrasions, lots of missing teeth, and presence of deciduous teeth. Her joints. She's got good joints. They are not degenerative joints. You can see that there's areas of overload. There's functional spaces reduced, so probably the disc is not in place. And she has functional adaptation. But we decided to treat this woman. We decided to eliminate her pain. We put a distraction splint, an anterior splint, a full coverage splint. We did physiotherapy. We did stretching of the joints. We did our TMD protocol. 6 months of treatment, and she is totally asymptomatic, of course, more class 2 and open-eyed. What they were not able to achieve after 6 years of everything you can probably imagine, we achieved it in 6 months. What did we do? We found the stable mandibular position, an orthopedic stability in the joint, nothing else. Is it here, there? Is it centric relation? Who cares? It's just a stable position, and a stable position can be achieved. And what does Dr. Occlusion says? He says that the orthopedically stable joint position is one that is against the posterior slopes, there's eminence, superior anterior position of the articular fossa. And it's dictated by the muscles and the teeth. See, the teeth are responsible for orthopedic instability. The teeth get in the way. How can you possibly say that we have to treat our patients according to a biosocial model when the teeth, in many instances, get in the way and are the reason, and probably the most important reason, of many of our TMD patients? Oh, see, that's why I don't like to download my presentations. Jesus. It's not working. There's a movie there. No, I'm not going to skip.
We're into.
I'm sorry. The good news is now I get an hour and extra. Okay, so we started with our distraction splint, which helps our patients exercise. An anterior splint, we like them to stop clenching at night. It works wonderfully, and then they wear a full coverage splint. This is a patient after 6 months of treatment. She is totally asymptomatic, but as you can see, more class 2 and an open bite. So we decide to show you how this patient now was biting. See, when this patient was biting, she was hitting on the back teeth. And no one will hit on back teeth. Nature will always avoid a first contact. And so what she has to do is the mandible has to come down and back. And this is what Occlusion refers to as orthopedic instability. See, the patient has a decision to make. Or he bites with his teeth together and the condyle out of the fossa, or the condyle is in the fossa and the teeth do not come together. And this is exactly what we did. And if you want to believe this, look at this interesting picture. Why would nature not wear down this second molar? Why has this 46-year-old man worn down his entire dentition and yet has not touched his second molar? Imagine how he has to bite to be able to avoid this second molar. His mandible has to come down forward to be able to not touch this second molar. This man does not have a stable condylar position. He does not have orthopedic stability. It's impossible. And he pays a price, just like Occlusion said. You might get tooth wear or you might get TMD alterations. See, what is going on is that the neuromuscular system is going to avoid a first contact. And it's going to do it at the expenses of orthopedic stability. So we were able to do our pre-prosthetic orthodontics. We put implants, we raised the vertical dimension, she got gingivectomies done, and she will soon get reconstruction of her teeth. This is the patient. When she first came to our office, she was 23 years old. She's now 25 years old. Look at the difference in masseter muscles. She is definitely not clenching as she used to do. And before I took the airplane on Friday, I interviewed this girl. And I would like you to look at the body language, at the facial expressions. There's no sound here.
¿Te duele algo, Laura?
Nada. Nada. Abres y cierras perfectamente.
You
¿verdad?
open and close perfectly, yes.
Bien. Laura, escuétame.
Tell us a little bit about your past history.
¿Cuántos años tuviste con dolor?
How long have you been with pain?
Yo recuerdo 10 años. pero
I can
creo que
remember at
años
least
más.
10 years of pain, but I think it was more.
¿Dónde?
Where did it hurt?
Oídos sobre todo y cabeza.
Ears, headaches, around the ears.
Te pusieron todo tipo de farmacología, ¿verdad?
They gave you different drugs, lots of different injections.
Fármacos, y con eso, ¿qué
What did they
consiguieron?
achieve with
Con
this?
eso conseguían aliviarme los
The pain went away the first 3 days after the drugs were administered,
fármacos y luego volvíamos a lo
and then they came back.
Bien, nosotros pusimos una férula.
We placed a splint and stabilized your mandible, orthopedic stability.
Tardamos en quitarte el dolor.
How long did it take
mismo.
us?
6 meses.
6 months.
Y han pasado ahora desde que te pusimos la
How long has it been since you've been without pain?
Es un año aproximadamente.
1
¿Has
year.
vuelto a tener dolor?
Nada,
No pain.
¿Hemos dado algún tipo de fármaco?
Any drugs? No.
¿Y llevas cuánto tiempo
How has this changed your life? Look at the facial
¿Y
expressions.
cómo ha cambiado tu vida?
en todo.
Por ejemplo,
Pues ya no tengo.
I can eat all foods. I can chew.
Ahora yo misma digo, ay, no me como
I
esto,
can wear a
no
ponytail. She could not even put a ponytail. I can wear earrings.
entiendo, pero como absolutamente de todo. Me puedo hacer coletas, me puedo poner pendientes, puedo escuchar música alta.
I can listen to loud
Me
music.
puedo poner una gafa.
I can wear
y hasta
sunglasses.
puedes bailar sevillanas.
And you can even dance sevillanas.
Y hago deporte.
Muy bien, Laura, muchas gracias, guapa.
Nada.
See, she was treated for 6 years according to a biosocial model. It didn't work. And in 6 months, we were able to resolve this girl, and she's been in treatment now for more than a year, 18 months, and she hasn't had pain again. And all we did was achieve orthopedic stability. See, the literature might not hold all of the answers. It just might not hold all of the answers. Because, see, when you read the National Institute of Dental and Craniofacial Research, they tell us avoid treatments that cause permanent changes in the bite or jaw, such as crown and bridge work, orthodontics, grind the teeth. That's really nice. But you know what? They've tied our hands. There is nothing we can possibly do to these patients if we follow these guidelines. And I can only show you 3 patients, but I guarantee you I could show you 3 dozen, 6 dozen patients because I've been doing this for many, many years. And see, it's not whether an articulator is evidence-based. It just helps us diagnose the vertical problem. And you cannot diagnose correctly a vertical problem if you don't have an instrument that will help you decide how to diagnose this vertical problem. And she has a vertical problem. And the vertical problem is making her unstably, orthopedically unstable joint position. Let's take patient number 2. There's a lot of mothers in this room. How would you like your 13-year-old girl to have headaches for 2 years, joint sounds, disc displacement, muscle symptoms, and pain around the ear, has been seen by ENTs, neurologists, pediatrician, and last but not least, the TMD specialist. No one even looked at her teeth because that wasn't a problem. The literature doesn't say that's a problem. But see, when I look at her teeth, the first thing that comes to my mind, this is an unstable occlusion. And an unstable occlusion, in many instances, will not let you achieve orthopedic stability of the joints. Look at the amount of tooth wear. Is this normal in a 13-year-old girl? We're talking about a 13-year-old girl who's already worn down at least 1.5 to 2 millimeters of her upper incisors and about 1.5 millimeters to 2 millimeters of her lower incisors. Is this physiological? Is this what we want for our patients? Do we close our eyes? See, what did Dr. Occlusion say at the beginning of my talk? Orthopedic instability might be the cause for dental wear, TMD alterations. There's no doubt in my mind that this dental wear is directly related with orthopedic instability of the joints. And let's stop talking about centric relation. I'm tired of it. And just like I asked Dr. Rinchus in Italy, I'm going to ask Dr. Kandasamy, although he's not in the room, will he please stop calling us gnathologists? I don't call him anything but an orthodontist. I'm an orthodontist, just like him. And I don't like to be called these individuals who are nathologists, occlusionists, functional, whatever. That's not fair. I'm an orthodontist, just like he is. Let's have a little bit more respect for each other. When I look at her Panorex, I see that she's got joint difference between right and left, and she's got a very large antigonial notch. This is indications of hyperactivity of the masseter muscle. When I look at her head x-ray, she has a good skeletal pattern. However, when I look at her right condyle, you don't have to be a rocket scientist. You don't have to read all the literature to know that this condyle is not in the correct position. Call it whatever you want, but it's definitely not a stable joint position. Because what a stable joint should look like is this: upward, forward, and against the eminence, and hopefully with a disc interplaced. See, it makes me laugh when they say, oh, yesterday it was here, today it's here, tomorrow it's here. They're still looking for the Shangri-La. You know, do we criticize medicine for going forward? Do we criticize medicine because they've changed their treatments from 10 years ago to today? We applaud medicine. And I think it's time to realize that what we have done in the last 20 years is look for a stable condylar position. And even Jeff Occlusion will tell you this position will never change in another 20 years or 50 years, because we finally found what we feel is the correct position, but it's a muscular position. We don't call it symmetric relation. I don't care if it's here, 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 here. All I know is that this girl has orthopedic stability. And when we look at the works by Culbersh and Freeland, we know that the majority of the prematurities are in the second molar area and brings the condyles back and down. Let's look at the right joint, the left joint, excuse me. It doesn't look very nice, does it? It's lost a lot of morphology. It's lost a lot of size. There's been some degenerative joint disease. Is this normal in a 13-year-old girl? This is how it should look. And look at the fossa. It's totally flattened down. It's adapted. But she hasn't adapted. She has been headaches for 2 years and joint sounds. And when you look at the University of Minnesota, they took 200 consecutive orthodontic patients. This was done by a radiologist, not by a biased orthodontist. 18% of everyone who walked in the orthodontic clinic had temporomandibular joint findings that were significant enough for further follow-up or referrals. This is why we use CBCT. There's a need for CBCT. So we started our routine anterior splint, distraction splint, physiotherapy, stretching, no drugs. And what do we see? This girl now has a very large class 2, a very large open bite. But guess what? Totally asymptomatic. 7 months, totally asymptomatic. No more headaches. And look at the girl. She looks like a happy girl. And now, let's look at the joints. Look what the joint was. It was down and back. No one in this room likes that joint position. It's not correct. But now when you see where the joint was taken, let's just call it orthopedic stable position, okay? Let's not play these games about it's your game, it's my game, it's centric relation, it's not centric relation. That doesn't help any of us treat patients. This is about patients. See, this patient is now in a stable orthopedic position. She can now rotate and translate. But the problem is that she has a large class 2 and an open bite. See, this is not difficult. And when we look at the left side, we see the exact same thing. How the joint came up and forward. Why? Because like Jeff Occlusion says, this position is dictated by the teeth and the muscles. The muscles have taken the joints to this position, and we got the teeth out of the way. But of course, she has one contact in the back, and she has a class 2. So now what do we do? What do we do? Because we've resolved the symptoms, we've found a stable joint position, but now we have a problem. She's class 2. But like Strati Regalis and me were talking last night, and Strati says, Domingo, the good news is we have the means to be able to treat this girl because we have models that are mounted on an instrument. And what we can do now is take off the back teeth out to rotate and see if it's a vertical problem, an anterior-posterior problem, or a transverse problem. You can't do that if you don't have the instrumentation. This is her head X-ray. As you can see, she's more class 2, more open bite. And what we are seeing is that the teeth are occluded, but the condyle has an orthopedic unstable position. But now, once we put the condyle in an orthopedic stable position, she bites on the back teeth, and as you can see in the head X-ray, her mandible went down and back. So now what we have to do is maintain the orthopedic stability and have the teeth occlude. Simultaneous bilateral contacts with the joints in a stable orthopedic position. So we decided to start some vertical control. And what vertical control means is we maintain the condyle in its position, it's a stable position, she continues to be asymptomatic, and we start to intrude the back teeth. And you can see on this picture, we are quite successful in intruding the first 6-year molars on both sides. You can see the 6-year molars are totally out of occlusion, but we still have big contacts on the second molars. We're not able to out-to-rotate the mandible. So I go back to the instrumentation, I take another set of models, and what I do is I intrude the back teeth, and I realize that if I am able to intrude the second molars, I will be able to out-to-rotate the mandible and achieve my goal. And thanks to my friend Dr. Doug Knight from Kentucky, we use these coil springs, we run them through the arch wire, we have skeletal anchorage, we put plates and screws on right and left, we put screws in the palate, and what we are doing is intruding the 6s and the 7s to be able to out-to-rotate the mandible. This will help us maintain the condyle position. It will change the occlusal plane. It will make it more divergent with the eminence. As Dr. Tanaka says, this will take a large amount of overload on the joints away when you have divergent planes. And if you look at the patient 6 months later, we've closed her bite. She bites in class 1. She no longer is class 2. And we were able to maintain the joint in an orthopedic stable position and bring the teeth together. But not only that, as our friend Anika Isberg says, children and adolescents with TMD disc displacement are at risk to develop facial asymmetry when unilateral and mandibular retrognathia when bilateral. So see, if we are able to resolve this displacement with this type of treatment, and usually we are, because they are young children and the posterior ligament has not lost its properties, we can do this girl a lot of good, not only for her dental aesthetics and facial aesthetics, but for her TMJ health. And I interviewed this girl 6 months ago, and I interviewed her this Friday. And I would like you to see both interviews. And once again, look at her face. She's going to describe exactly what she was going through and what was happening. Open and close, Maria. See, this is after splint wear. You can see she has a class 2 and the open bite.
Muy bien.
How are you, Maria? Muy fine. What is the problem?
Pues antes
Before, when my mouth was closed for a long time,
luego no podía abrir la boca.
it was impossible to open my mouth.
Clac, clac.
My joints went clack, clack.
Estoy mucho mejor.
But now I have no more sounds. I feel much better. So no more clack clack? Are you better? Yes. Open your mouth, please. No more sounds? See, what did we do? As you could see in the x-ray, we brought the condyle up and forward. We didn't, the muscles did. It's a muscle position. We were able, and luckily, to be able to put the condyles back on the disc. She now opens perfectly. She has no more joint sounds, no more pain. And now the good news is she bites perfectly in class 1. And I want you to see this. Open and close. This is Friday. Open and close. Open a little more. You can see no overjet. Perfect overbite. Class 1.
Bien. María, vamos a ver, desde la última vez que te entrevistamos.
When was the last time we interviewed?
¿Has vuelto a tener dolor?
Since the last time we interviewed you,
¿Los ruidos han vuelto?
have you had joint pain again? No.
¿Sigues sin dolores? Qué bien.
Any
¿Cuánto
joint
va a
sounds?
pasar eso?
No. No pain, no joint sounds. How long has it been now?
¿Un año? ¿6 meses?
6 months, 12 months?
¿Qué? Más o menos un año,
Yes,
¿verdad?
more or less 1 year. So 1 year with no symptoms. How about the surgical plates?
¿Y qué tal con las placas?
Bien.
Bien.
No problems.
Estupendo.
Thank you, María.
Muchas gracias, María.
It's incredible how our patients forget. The reason why I asked her about the skeletal plates is she had lots of inflammation, lots of swelling. She had a very rough time after we placed the plates, and yet she completely forgot. But see, this is what it's all about. It's not about telling us if the literature says this or the literature says that, if this article is good or this article is bad. It's about treating patients. And we have to treat patients. That's why we're here. And see, if we tell our patients, you're a biopsychosocial model, go see a shrink, they're going to get drugs. And if there's something that bothers me more than anything else is giving these patients drugs. And I was just in a European country at the TMD department. I'm not going to say the city or the university. And the only thing they did was administer drugs and put splints. It's interesting, drugs and splints. I have not given a patient an aspirin in 10 years of treating TMD. I don't think they need aspirins. I don't think they need heavy-duty drugs or injections. I think we have to do a differential diagnosis. And how do we do a differential diagnosis? Well, I'm sorry, because Dr. Kandasamy just told us it's not evidence-based. We use splints. And splints do wonders for stabilizing and achieving an orthopedic stable position. And once we achieve this orthopedic stable position, we, of course, want to know, did we achieve resolving the symptoms of our patients? That's what it's all about. See, I can put the condyle beautifully placed in the fossa, but if my patients still complain, what's the point? See, the important thing is that the patients get resolved of their symptoms. But then it's time to do the final treatment plan. And luckily, we have the instrumentation that helps us achieve the final treatment plan. Let's look at patient number 3. Beautiful girl. So you can see class 3 mandible, slight asymmetry to the right, slight maxillary hypoplasia, lack of malar prominence, constricted maxilla, black corridors, which is usually directly related with a maxillary hypoplasia, a long lower third, lip incompetence, cant of the maxilla, and an asymmetric smile. This is her occlusion. And you look at her teeth and you say, she has no tooth wear. Because, see, not all patients who are with unstable joint positions have tooth wear. There also has to be parafunction, and not everyone parafunctions. But see, she does have joint problems. And now when we look at her mounting, yes, we see a slight difference in between RC and OC. And, you know, that's not what's important. What's important is to do a diagnosis. And unfortunately, she had orthodontic treatment many years ago. And as you can see from the lower arch, there's a lot of dental compensations that were done to be able to try to compensate a skeletal asymmetry. But she still was asymmetric. And when we look at her joint films, she has joint sounds, she has pain around the ears, she has neck and shoulder pain, she has muscle pain, headaches, and morphological changes. And you can see that on her right TMJ, she has disc displacement, or at least she's on the posterior band of the disc, and she recovers it. And on the right side, she's on the posterior band. So she does have joint sounds because she's slightly back, and when she opens, she clicks, and when she closes, she clicks. But she has lots of pain around the shoulders, the neck, and we decide that we're going to do what we like to do. We're going to stabilize and achieve a stable joint position. And this is a nice way to do differential diagnosis, because if my patients don't improve with my treatment, it's not for me. It's a facial pain patient, and I know exactly where I have to send these patients when I cannot achieve the resolving of the symptoms. But, amigo mío, if I am able to resolve the symptoms, now it's up to me to find the final solution so that that patient has a stable occlusion with a stable orthopedic position of the joint. So as you can see, the bite opened up, she became a little bit more asymmetric, and when we look at her head x-ray pre-splint and post-splint, we can see that she went down and back, and a slight open bite. We do our final diagnosis. Because of the class 3, because of the asymmetry, because of the open bite, we will not be able to achieve a good result with just orthodontics. So we decide to offer the patient a surgical solution. It's the only way we're going to be able to give her a good overjet, good overbite, simultaneous contacts of all teeth with the joints in a stable position. The patient decides that she wants to go to surgery, so we do our pre-surgical orthodontics. Once we feel the case is prepared, we splint the patient once again to be able to do the final model surgery, and this is so important in asymmetric cases because we need to know the true extent of the asymmetry to be able to tell the surgeon how much he has to move the mandible to the right, to the left. We have to do a very good mounting to know the cant of the occlusal planes, and look after dental decompensation and stabilizing the mandible how this patient really bites. She's got an asymmetry, she's got a class 3, and an open bite. See, it was never an orthodontic case. Even when she was 8 years old, it wasn't an orthodontic case. They tried, but it was a skeletal asymmetry, and we have to know our limitations. So, Dr. Lucho Quevedo from Chile gave a course in San Sebastian, and Dr. Quevedo operated this girl, and he did a Lafort. He advanced the maxilla 4 millimeters. We impacted 3 in the anterior, and then he did asymmetric expansion of the maxilla to be able to align the occlusal plane. And then he slightly rotated the maxilla to the left because she also had an asymmetric maxilla, outer rotation, and chin advancement. This is the case post-surgical. As you can see, we're now doing our post-surgical orthodontics, trying to achieve a good occlusion. We like to do some intra-treatment mountings to make sure that we have bilateral simultaneous contacts with a stable joint position. And this is the patient post-surgically, the day we took off the appliances. As you can see, we achieved our occlusal goal, but see, this is not enough. This doesn't tell the whole picture. Where are the condyles? And this is what we always have to look at. This is our patient 18 months post-treatment. We're able to maintain her occlusion. She's got a good overjet, good overbite, good class 1 occlusion. When you look at her facial aesthetics, it's not easy operating a beautiful girl. Dr. Quevedo did a wonderful job, brought the mandible forward, lowered the third, facial third, gave her good dental exposure at rest, a nice profile, and a beautiful smile. And when we look at the x-rays post-treatment, we can see the changes that were achieved, how the lower third was shortened, how the mandible came forward. And if you look at the right green on the right side, how the maxilla is more green, on the left side it's more brown, we can see exactly how he rotated that maxilla, and that's why we see difference on the right and left side, and then the nice chin projection of this case. When we look at her x-rays, pre and post, on the left it was the pre-treatment condyle. As you can see, it seemed like it was slightly back and slightly discentered, but if you look at the condyles post-surgery, it's in the exact same position. So see, this for me is a stable joint position. It doesn't have to be the perfect centered condyle, and that's another fault of the literature. We cannot look at x-rays and say this condyle is in a good position, this one is not in a good position. An x-ray will never tell you the position of a condyle. It will just tell you if it's more or less in the ballpark. If we look at her left side, see, it wasn't that this girl was down and back, she was just asymmetric. So when we look at the front condyles from the front, we see that they're more centered. On this side, we see it's more centered. So what we did was actually more transverse changes to be able to center the mandible. And I interviewed this girl, and you really have to look at her facial expressions, because this is a girl who went through pain, and don't forget she went through bimaxillary surgery, or maxillary surgery and chin. Open your mouth, Ayana. Now we've achieved the arc of closure. She bites in one position. She opens perfectly, 52 millimeters. We want to make sure we have no posterior interferences. Good movements of the mandible. And one bite. When did you come to the office for the first time? A year more or less?
A finales del 2005, diciembre, sí.
December 2005. 3 years since you came. What was your chief complaint?
Dolores de cabeza, dolores de
Headaches, mandibular pain? Which side? Mainly on my left. We diagnosed your case and decided to start with conservative treatment with a splint. What did you see at the splint? Absolutely, all my pain went away. All of it. All the symptoms disappeared, yes. We then decided that you needed orthodontics and orthodontic surgery. If I remember well, we operated you March 2008. No, February 2008. Are you wearing a splint at night? No. What do you feel at the moment? No more pain? I chew very well. Everything is perfect. Recently you mentioned to me that your physiotherapist saw you. My physiotherapist I've been seeing since I was 18, 19 years old. How long ago was that? What did your physiotherapist say to you? After surgery, I went to see him, and he noticed that my neck muscles on my left side had really improved. More relaxed. Looking back, Oyana, would you go through all this treatment again? Yes. Are you sure? Without a doubt. Absolutely sure. Thank you. So see, when I see patients like this, who have gone through this treatment, and this movie was made at least 2 years ago, I can tell you I see this patient still. I live in a small city. I see my patients everywhere. 5 years post-treatment, she is exactly the same. And now I look at these research, and they tell us, avoid treatments. Avoid treatments. No permanent changes in the bite or jaw. If I told Oyane, my patient, I'm not going to change your bite, I'm not going to do treatment because it's not what I should do for you, she would say, what are you saying? See, it's about patience, it's not about the literature. And they are tying our hands. We cannot allow this to happen. We have to defend our specialty. Our specialty is a clinically based specialty. Yes, it needs to be evidence-based, but the evidence doesn't give us all of the answers, and we have to continue looking towards the clinic, and what we need to do is have the research look at our cases and do a clinically based research project and get the clinicians and the researchers together and not go everyone in parallel. And like Sam Higgins says, the hypothesis of an occlusal causation for TMD remains viable and should be further challenged in the future by a higher level of scientific inquiry. And to paraphrase my good friend Jeff Okerson for the last time, orthodontists need to establish their treatment goals by considering both the occlusal position and the stable joint position. See, it's not just about teeth. And everyone loves to show this. But I was in the airplane last week and I saw, without a solid base, a pyramid will not withstand the passing of time. And the good news that we, the clinicians, are the base of the pyramid. I still think that clinicians have a lot to say, and clinicians need to treat their patients based on evidence-based, but also we have to be very critical with the evidence. Thank you.